Ladies and gentlemen, good afternoon and welcome on this joint IUGA ICS session. As past president of IUGA, I'd like to thank ICS for giving us the opportunity to have a joint session on their conference on an important topic, namely the perspectives of the treatment of vaginal prolapse and then vaginal prolapse, symptomatic vaginal prolapse. Let me first introduce you to my co-chair, Professor Paulo Palma from Brazil. And let me also introduce the three speakers here, Professor Kari from Norway, Dr. Rani Taka from the UK, and Dr. Roger Domovkovsky from the US. We will start the session with two cases, and you are allowed to look at the cases that will be introduced briefly, and then you have to make a choice between 5 therapeutic options we have on the slide. So we want you to raise the hands. We will tell you for the first option, for the second option, and so on. And we will do that again after the three presentations. And then after that, we'll start a roundtable discussion with you, with the audience, and with the speakers.
Good afternoon. This is a 51-year-old lady with 3 normal vaginal deliveries, premenopause, an eventual history. She complains of vaginal bulging, lower abdominal pain since 12 months. Upon Valsalva, bulging of the anterior vaginal wall to the hymen, normal sized uterus with no descent, no urine loss upon coughing, POPQ stage 2, the AA -1, BA 0, and point C -8. The GH was 3, the PB 3, TVL 10, the AP -3, BP -3, and D -10. Well, what options are here for this lady? We have a pessary, pelvic floor physiotherapy, standard anterior repair with mesh, abdominal sacrocolpopexy. So at this point in time, we would like to ask you to raise your hand. Who of you would recommend the pessary for this lady?
Please raise your hands if your first choice of treatment for this premenopausal lady would be the use of a pessary. Okay?
1, 2,
and there, 2,
3, 4. Okay.
So, who would take the second option, pelvic floor physiotherapy?
Wow.
Well, okay, that's good.
Okay.
Who would embark on standard prolapse surgery?
Okay.
Okay. Who would start with, in this primary case, with the use of a mesh, an anterior and posterior repair? An anterior repair in this case only, with mesh? Nobody?
Zero.
Okay. Who would prefer an abdominal approach? An abdominal sacrocolpopexy. Okay, also that's clear. Then we move on to the next case. Can we have the next slide, please? The next case is a 67-year-old lady with the same previous history. In fact, it's the same lady, just 16 years older. And in the meantime, she developed a posterior recurrence of her anterior wall prolapse, and she developed a posterior prolapse and also some apical descent, still with the uterus inside. As you can see, the POPQ score from the slide shows a descent from the posterior vaginal wall and from the anterior vaginal wall, but also from the uterus. Again, we would like to ask you to vote by hand. What are your options? Who would prefer to send this lady would prefer the use of a pessary. Okay, that's a little bit more. We would use or recommend pelvic floor physiotherapy. Okay. Who would recommend a standard anterior-posterior repair, and when necessary with hysterectomy or anything like that? Majority, okay. And who would use a mesh procedure for this lady with a recurrent prolapse? Okay, and the last question, of course, who would embark on an abdominal approach? Okay, thank you. We'll look what changes during these 3 presentations. The floor is yours, Dr. Kari.
First, I would like to thank the scientific committee and especially Professor Monse Espuna for inviting me to give this talk on peripheral muscle training for pelvic organ prolapse. There's no disclosure to my presentation here. Surgery for pelvic organ prolapse shows a high rates in both of these studies, and it's also increasing throughout the world. However, the studies have found that between 13 and 58% of women need reoperation after pelvic organ prolapse surgery, and is therefore not that efficient as we want it to be. And pelvic organ prolapse recurs in up to 70% found in this study. And there, as we all know, there are complications, especially for mesh surgery. One option for treatment is no treatment. Leave the women alone. Because in this study from Sweden, Middle found that watchful waiting for 5 years was also quite effective. 47% of the women were unchanged when it comes to POPQ stage. 40% had regression and 13% only had a progression of the pelvic organ prolapse. So maybe watchful waiting could be one option as well. I'm going to talk about pelvic floor muscle training, and Kegel postulated back in 1952 that with adequate pelvic floor muscle training, the woman learns to maintain the perineum, the bladder, and the uterus in a higher position. The slack in the supporting muscles will be taken up, and the vagina will become longer and tighter. Today, we have more detailed theories on how strengthening of pelvic floor muscle training would work on the structural support. So we try to lift the organs into a higher anatomical location. We want to try to get hypertrophy of the muscles. We want to narrow the levator hiatus. And we also want to have a certain stiffness in the connective tissue by the training program. However, clinical practice should change based on positive results from randomized controlled trials and systematic reviews. And I'm now going to go through the 8 randomized controlled trials that we have in this area. The first one came out in 2003 from Thailand. So this is quite recent research when it comes to pelvic floor muscle training for pelvic organ prolapse. This was a randomized controlled trial on 682 women of more than 60 years. The intervention was a 2-year intervention with asking the women to do 30 pelvic floor muscle contraction per day, and then they had a follow-up every 6 months, so 4 visits to the hospital. But they were also asked to eat more fruit and vegetables and to drink 2 liters per day to try to avoid constipation. The results show that there was a 72% worsening of severe prolapse in the control group, while it was 27% only in the pelvic floor muscle training group. They didn't show any effect on mild prolapse, and that was quite surprisingly, but they showed effect on severe prolapse only. The next study came out from Tunisia, from Grobe and co-workers in 2008. They had 47 women, and the mean age was 53.4 years, and they had grade 1 and 2 cystocele. They had a group that had 12 weeks of physical therapy with weekly pelvic floor muscle training, plus lifestyle intervention and home exercise, and this was compared to no treatment. The results show that there was a significant reduction of heaviness symptom in the pelvic floor muscle training group compared to the control. And they also measured what they called urinary handicap and found a significant improvement in the pelvic floor muscle training group only. However, they did not assess the stage of prolapse in this study. Then it was a feasibility study for a bigger RCT on peripheral muscle training from United Kingdom. 47 women and more than 80% of the participants had cystocele. This was a 16 weeks intervention, and one group had 5 visits with a physiotherapist and then were asked to do 6 sets of peripheral muscle training contractions daily, and they used a diary. And this was compared to a lifestyle advice sheet. They used POPQ, assessed prolapse symptoms, quality of life and interference of daily life, self-report of change in prolapse, and Oxford grading for peripheral muscle strength in the training group only. Here are the results, and the POPQ data were missing for many of the participants, 27 out of 47, so we have to bear that in mind. But there was significant improvement in the rest in prolapse stage in the peripheral muscle training group. Also significant improvement in symptom score, no difference in quality of life, but a significant improvement in peripheral muscle strength within the peripheral muscle training group. Then it's our study that was published in 2010 from Norway. Our interventional protocol was a 6-month intervention. The control group was asked to do the NAC and taught how to do that, and they had information about toilet habits, meaning not to strain on toilet. The peripheral muscle training group had the same information and also were taught to do the NAC. Then they had individual treatment with 8 to 12 contractions 3 times a day, and to notify this in a diary as home training. And then weekly visits for 3 months with a physical therapist, so once a week, and then every second week for 3 months following that. We had 109 women randomized, we had only 2 dropouts, and it was a high adherence to the exercise sessions. Mean age was 48.8 years, and mean parity was 2.4. We had 19 with POPQ stage 1, 65 with POPQ stage 2, and 24 with POPQ stage 3. We improved strength, and you can see that there's a really huge effect size here between the exercise group and the control group. Effect size is 1.2. And also muscle endurance was significantly improved and much higher in the peripheral muscle training group compared to the group that was doing the NAC. The results show that we changed the POPQ stage with 1 stage with 19% in the exercise group compared to 8% in the control group. And symptoms was highly significant in favor of the peripheral muscle training group when we are talking about bulging and heaviness, both in frequency and bother. However, more importantly perhaps is the morphological changes that we were measuring using ultrasonography. And we are here looking at the results with the difference between exercise and control. We improved the muscle thickness with 15.6%. We reduced the hiatal area with 6.3%, and we reduced the muscle length with 4.2%. And very important, we lifted the bladder neck with 4.3 millimeter, and also the rectal ampulla with 6.7 millimeter. And when we asked them to Valsalva, there was less opening of the hiatal area in the peripheral muscle training group compared to the other group, maybe indicating an automatic function of the training program. After our study, one study came out from Brazil in 2011. 37 women with mean age 55 years of age with pelvic organ prolapse stage 2, and this was anterior and posterior vaginal wall on POPQ. This was again a single-blind randomized controlled trial comparing lifestyle advice with lifestyle advice plus peripheral muscle training. 14 weeks intervention and 7 visits with a physiotherapist, and then added with home exercise. The results show that there were 0 dropouts and 91% adherence to the home program, so very good, and 71% to the entire program. They showed a significant greater improvement in strength and endurance and EMG parameters in the peripheral muscle training group, and also significantly better change in stage of pelvic organ prolapse and symptoms and quality of life. There are 2 abstracts in this area, one from Hagen and co-workers in 2011, both from the ICS, 448 women with symptomatic pelvic organ prolapse stage 1 to 3, and 74% of this population had stage 2. Again, this compared lifestyle plus 5 appointments with physiotherapist over 16 weeks with lifestyle alone. They also had a high follow-up and high adherence to their program. And there was a borderline significant improvement in prolapse stage and significant improvement in bulging. The other abstract was from Australia, from Froley and co-workers, 168 women with symptomatic POPQ stage 1 to 3, and 80% in this population had stage 2. It was the same intervention as the one from Hagen, and the results didn't show any effect on stage of prolapse, but significant improvement in AP and BP symptoms and peripheral muscle endurance. Then the last controlled trial is from Kashyap, came out this year. 140 women, mean age 47 years of age, and the POPQ was again 1 to 3. And in this study, a large proportion had stage 1. This was a 6-month intervention, and they all had vaginal palpation to start with. Group A had 6 sessions with a physiotherapist and then self-instruction manual and home exercises. And the home exercises were 3 sets of 10 contractions per day. Group B had 3 follow-up sessions with the physiotherapist. Again, they could see the difference in dropout between these 2 groups, with Group B having much more dropout than the other. Adherence was unfortunately not measured. There was a complete relief of symptoms in 24.5% in the group with more visits with the physical therapist, and there were no effect in the other group. And there was a significant improvement in POPQ stage 1 and 2 in Group A. So a big question, I think, in this audience is also, should peripheral muscle training be added to surgery? And to date, unfortunately, there are no randomized controlled trials evaluating the effect of peripheral muscle training in addition to pelvic organ prolapse surgery on recurrence of pelvic organ prolapse symptoms or POPQ stage. So what about lifestyle? There are no RCTs in this area. However, lifestyle was controlled treatment in the RCTs on peripheral muscle training, and it was usually stop straining on toilet and also using the NAC. It was less effective than peripheral muscle training in all the randomized controlled trials. However, adherence was not measured, so we do not know if they follow the lifestyle program that they were offered. Albert Einstein has said, intellectuals solve problems, but geniuses prevent them. And I do not think that physiotherapy or peripheral muscle training can put this back. So we have to start at an earlier stage. But there are difficult to do primary prevention studies in this area because we are unlikely to have an ongoing high-quality RCT for 20 to 30 years, which is what we need to really see the effect of prevention. If we look at some of the trials that we have, this is a study from Brecken and co-workers showing that there was a difference in peripheral muscle function in women with and without pelvic organ prolapse, and very highly significant as well. And also using the morphological study that we have published, there was a significant and clinically relevant morphological changes seen after peripheral muscle training in women with pelvic organ prolapse. So this can be used as at least some evidence that it may be possible to do prevention. However, I don't think we can implement, or this could be the discussion, could we then tell women that they should do peripheral muscle training to try to avoid pelvic organ prolapse? So the conclusion for peripheral muscle training for pelvic organ prolapse is that we have a strong theoretical rationale for peripheral muscle training. There are 8 randomized controlled trials and a systematic reviews in this area, and it's level A evidence to do peripheral muscle training to treat pelvic organ prolapse. The improvement is 1 stage. No one has shown anything more than that, so 1 stage lift. But it always improves symptoms, which is maybe the main factor to avoid surgery. However, I need to say that anatomical changes need proper training. So also in this area of exercise science, we need to do strong interventions to get the effect. However, prevention is the best cure, and I think the aim for all of us is to try to avoid surgery for most women, although some may need it, but not all of them. So thank you for your attention.